Welcome back to RN Toolkit. Today we'll review how to describe skin lesions using the right terminology and identify common bacterial, viral, and fungal infections. Conditions like impetigo, syphilis, varicose, and herpes zoster, herpes simplex, and chickenpox will be explained with a nursing focus on recognition and treatment.
Okay, let's put you in a real-life scenario. You're in clinicals. You see a lesion like this, and your preceptor says, describe that for the chart. What do you call it? Knowing the right term isn't just about acing your exams. It's about clear, precise communication that actually leads to the right diagnosis.
And that's exactly what this is all about. We're going to give you the foundational language and, maybe more importantly, the pattern recognition skills you need to feel way more confident in your derm assessments.
So, here's our game plan. We'll start with the essential language, the words you need to describe what you see. Then we'll take that knowledge and apply it to identify some really common bacterial, viral, and fungal infections. And we'll wrap it all up with a simple framework you can start using like tomorrow. First up, the language of skin. You know, getting this right is everything. It's the shared vocabulary you'll use with doctors, specialists, and other nurses to paint a really clear picture of what's going on with your patient. Let's start with the absolute basics. A macule. This is just a flat spot. You can't feel it when you run your finger over it. It's purely a change in color. A freckle is the perfect example. Now, if that flat spot gets bigger than 1 centimeter, we just give it a different name, a patch. Simple as that. Okay, so what if you can feel a bump? Well, then it might be a papule. A papule is solid, it's raised, and it's pretty small, less than 5 millimeters. Think about a common mole that's a little bit elevated from the skin. Yep, that's a papule.
Now, what if that raised lesion is filled with fluid? If it's small, we call it a vesicle. This is your classic little blister, and as soon as you see a vesicle, your clinical brain should immediately start thinking about things like friction or, very often, common viral infections. A pustule is also filled with fluid, but the key difference, and it's a big one, is the kind of fluid. While a vesicle has clear fluid, a pustule, as the name kind of suggests, contains pus. Acne is the textbook example of a condition that involves pustule.
And this brings us right back to our very first question. A vesicle is a blister filled with fluid. A wheal, on the other hand, is totally different. It's not a blister. It's an area of swollen tissue, or edema. The perfect example of a wheal is a mosquito bite. See? They're both raised, but what's going on underneath is completely different.
Okay, so now that we have the vocabulary down, we can start putting it to work to identify some common skin infections. Let's start with bacteria.
A classic one you are definitely going to see in practice is impetigo. It's caused by staph or strep, and it's a perfect way to use our new terms. It starts out with vesicles or pustules, but then they rupture and form these really characteristic yellowish, kind of honey-colored crusts. The big clinical pearl here, it is super contagious.
All right, let's move on to viral infections. Now, with viruses, the type of lesion is important, for sure, but the pattern, how those lesions are arranged on the body, is often the biggest giveaway for what's really going on.
Take herpes zoster, or shingles. This is a reactivation of the chickenpox virus. The key feature here, and you have got to remember this for your exams and for your practice, is the distribution. It pops up as a group of vesicles along a single nerve path, a dermatome, and it does not cross the midline of the body. It's also usually very painful.
Now, let's compare that to herpes simplex. It also shows up as painful grouped vesicles, but, and this is the critical difference, it does not follow a dermatome. It can pop up pretty much anywhere, and it's often recurrent.
If you only remember one thing from this whole section, make it this. A vesicular rash that follows a dermatome and stops cold at the midline should make you think shingles. If it's just a cluster of vesicles that doesn't respect those boundaries, you should think herpes simplex. That pattern recognition is a massive part of your assessment. Last but not least, let's take a look at fungal infections. With these, the clue is often in the shape of the rash itself, especially what the borders and the center of the lesion look like.
Tinea, which most people know as ringworm, is a perfect example. And spoiler alert, it is not a worm. It's a fungus. The classic look is a red, scaly patch that grows outward, leaving a clearer area in the middle. It literally looks like a ring, and we just name it based on where it is. So tinea pedis is athlete's foot.
Another really common fungal problem is candidiasis, or a yeast infection. In the mouth, we call it thrush. You see those white patches on the tongue. On the skin, it absolutely loves warm, moist areas like skin folds.
You'll see this a lot in babies as a really bad diaper rash or in patients who are immunocompromised.
Okay, wow, we have covered a lot of ground. So how do we pull all of this together in a way that's actually useful when you're on the hospital floor or in a clinic? Let's build a really simple framework. Here you go, a super simple 3-step approach. Step 1, identify the lesion, give it the correct name. Step 2, note the pattern. Where is it? Is it in a line? Does it follow a nerve path? Is it clearing in the middle? And step 3, based on those first 2 steps, start thinking about the most likely cause. This systematic approach will make your assessment so much sharper and your documentation so much more professional.
Okay, let's end with one last question just to lock all this in. You see this exact patient. It's painful, it's only on one side of their body, it's a bunch of vesicles, and it stops dead at the midline. Using our framework, what's your number 1 suspicion? If herpes zoster or shingles immediately jumped into your head, then you have absolutely nailed the key takeaway. That is pattern recognition in action.